I think as dermatologists, because we can at least see the skin, we can do the review of symptoms, we are already dealing with a lot of these mimickers, we can be pretty frontline in starting the process for a lot of patients.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views at Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar, I've been thinking about a lot of different things of things that we overlook but happen commonly in dermatology. This happens a lot, right? Like we take things for granted, or if we don't understand a pathway or we don't understand something fully, but people come with symptoms, we're like, gosh, I don't know, maybe it's genetic, right? That's like our escape clause for everything, but we can go beyond that in integrative dermatology, no?
Yes, and while in most specialties in medicine, that kind of vague description will send the patient straight to rheumatology. In dermatology, we keep these patients, we work them up, and sometimes we find out all these interesting, mysterious syndromes that exist. And so, without being any more vague, let's invite an expert to help us go through these mysterious syndromes that we see sometimes in the skin.
Absolutely, and we're really lucky. I tell her this every time, and she is an absolute Renaissance woman. She's really pushing the boundaries on integrative dermatology, and boy, does she have the energy to do it too. So we're excited to have Dr. Sonal Choudhary. She is a board-certified dermatologist, fellowship trained in dermatopathology. She's faculty at the University of Pittsburgh, and she's the director of the Integrative Dermatology Clinic. And Hadar, to be honest, she's got a lot more in the bio. I just thought we don't want that to be the podcast. So we figured let's stop there. Sonal, welcome to the podcast. We are super excited to talk to you.
I'm super excited to talk to you guys as well. I have so much to say.
Yes, good. And I do insist on one item in your bio, and that is your time at the University of Miami. So there you go. I had to plug that in. So you heard it here first.
It's either the University of Miami or it's food, Hadar.
Yes, exactly. And so today, Sonal, we want to talk about this interesting entity called Mast Cell Activation Syndrome that we hear about more and more. Patients even are educated talking about this thing. Maybe we'll start by you telling us what the heck this thing is.
Absolutely. Raja said something already, which I want to start by covering. He said that when we don't know about something, we either call it genetic or something odd. I think with MCAS and some of the similar conditions, we almost have ignored it for too long, kind of tried to close our eyes and believe it doesn't exist. So basically, MCAS or Mast Cell Activation Syndrome, it's not just a single disease, it is a syndrome, and it is defined by a pattern of symptoms, which can result from inappropriate or even excessive mast cell mediator release. So that's where the mast cells come into play. They are otherwise completely normal immune cells. They sit in our skin, they are in our gut, they're around blood vessels, even near nerve fibers. And their role in our normal body, in our normal mechanism, is as actors of host defense, vascular regulation, and even neuroimmune communication that we talk about a lot in many contexts nowadays. But the problem is that with MCAS, that it's not that the mast cells are just existing. They're actually getting activated in a way that is leading to a lot of recurrent and significant symptoms. So there's three main pillars in which MCAS has to be sort of studied in or evaluated in. The first, that it has to be recurrent, okay? It has to be recurrent and episodic symptoms, very consistent with mast cell mediator release. So things like flushing, urticaria, angioedema, and then also things like GI cramping, diarrhea, hypotension, tachycardia. And these symptoms are happening in an episodic multi-system fashion. They're not like a vague chronic fatigue type of thing. On the second pillar, we have what we call more like an evidence for mast cell activation. So you have to be able to measure that the mast cells are truly activated. And in this case, the way to measure is you don't want the serum tryptase to be normal when somebody's having a flare, and there has to be this comparison from baseline to actual elevation. And the third, that the patient should be able to respond clinically to something that treats mast cell directed mediators like H1 and H2 antihistamines or leukotriene inhibitors or cromolyn. So these three are the main pillars. But the fact that it is very confusing in our real world practice is because the mast cells are normally involved in so many inflammatory and neuroimmune processes because they can interact with stress pathways, hormone shifts, allergies, barrier dysfunction. So a lot of things can just trigger MCAS for patients who truly have it. So I think it is a criteria-based diagnosis, and therefore sometimes there's overdiagnosis happening in this realm, which is why we get patients and we can be good first specialists who can bring this to the patient's attention, or if the patient is bringing to us, then we need to be able to clean it up for them a little.
Well, from the patient point of view for a second here, this sounds like mini anaphylaxis. And I can imagine a lot of times they come in really spooked, right? I mean, maybe not to us in dermatology, but they can come to the emergency room with, feeling like they got a massive allergic reaction and feeling like, like they're about to die. And I don't blame them for that. If you feel shortness of breath and hypotension, tachycardia, all these symptoms that we associate with bad things, that can be very scary for them, right?
Yes, absolutely. But like you said, they will not be the people who will be seen by dermatologist first, but it might be in an episodic manner in their history when they're talking to us about something related to the skin.
Exactly. And this is where, I think the challenge is because we are only getting one piece of a puzzle and we have to imagine the rest of the puzzle and by asking the right questions and diagnosing this. So, can you give us a sense of how common this is and how good are we in diagnosing it?
We can be pretty good at diagnosing it. It's not, I think it has been made a little more common than it is, because following the criteria and really leading to the actual diagnosis is believe it or not, is one of the conditions that's happening more. There's overdiagnosis right now because the moment people have some of these symptoms, and like you said, they're very educated on these things, they bring it to the specialist's attention, whether it's an allergist, whether it is a rheumatologist or their internist, and one symptom can get a little too taken out of proportion. So it is common enough, but the whole syndrome itself is not that common. Some of these scattered symptoms are way more common. Not to also complicate matters with some of the other things like POTS, postural orthostatic hypotension, tachycardia syndrome, and then also hypermobility disorders and EDS. So somewhere these things overlap a lot, and there is when a patient has one of these, they often tend to maybe present with the second condition, and it leads to this. When you read over the internet and stuff, there can be this question and concern and that they bring to their doctors. And as the doctors, it's our responsibility to start following the workflow and the differential diagnoses that we want to rule out. So to answer your question, the short answer here is the actual numbers are very confusing because they're not being diagnosed the way they should be right now.
Right. And so, from our standpoint as dermatologists, maybe we'll start there. What is the symptoms we see? You kind of mentioned the skin and how it can affect also the respiratory system, the GI system, right? What are we going to see? Because to me, it sounds like a patient comes in and we may think, oh, it's just urticaria, right?
Yeah, we absolutely can. But one thing we're very good at is pattern recognition. So even though a person walking in may not be labeled with MCAS already, if we start talking about the history, and most common cutaneous entry points, therefore, would be things like flushing, pruritus, I guess a lot of our patients have that, urticaria or angioedema, and dermatographism. So if I start with the first symptom, like say flushing, and it's pretty common, it's often very benign in nature. We see it in rosacea in women with, when they're in their menopausal timeline, with alcohol, with emotional stress, medications, even things like more rare things like carcinoid syndrome or pheochromocytoma. But not all flushing means there's mast cell activation syndrome. Also, like I've mentioned earlier, something that I keep repeating because this is very important, that if this symptom is episodic, reproducible, and is occurring with other systemic symptoms like GI cramping and lightheadedness and such, then we want to recognize them together. That's why review of system is so important. We can miss things if we don't ask that. Pruritus, on the other hand, like mast cell, are pretty central to itch biology. We already know that. And histamine-mediated itch, it tends to be pretty acute, often when associated with urticaria or even dermatographism. But chronic itch itself is not equal to having MCAS again. So what we're looking for, again, we're looking for that episodic mediator-related itch, not just like some chronic ongoing itch. So that's how we can differentiate them. Urticaria and angioedema are other common presentations, especially urticaria now with CSU being a very important topic with chronic spontaneous urticaria. We have to again sort of sort through it. There's a lot of sorting through that goes in this. Most patients with hives, they do not actually meet criteria for systemic mast cell activation syndrome. So the clues here are to basically try to push towards doing a review of system, getting that history. Did you ever have hypotension or pre-syncope episodes even? Did you ever have severe systemic reactions that were really disproportionate to what was going on? Dermatographism, on the other hand, it's super interesting because it's so common in the general population. So it can be a supportive thing, but it's definitely, again, not diagnostic. Not to forget,
Right.
we also have the entire cutaneous mastocytosis, where you're talking about actual clonal proliferation of mast cells, increase in mast cell burden, which is not what MCAS again is. It is the kind of hyperactivation of mast cells. So there's so many differentials that we see in dermatology, and we have to have that sort of level of suspicion that if there's more in the review of systems, things that I just mentioned, then we have to investigate. We have to keep our sort of radar high for that.
Wow, thank you for putting this kind of in order for us because as we started at the top of this episode, things can be very vague, right? People come with this vague complaint. I'm itchy or, I'm getting a hive here and there. And it's so easy to just say, here's an antihistamine, and they do well. Right, and then they go away, but then things keep going worse and worse, and you're still stuck with your early diagnosis. So that was really good kind of way of helping us to differentiate and go through the differential diagnosis and asking the right question. Okay, so now let's say I suspect this, right? And I'm saying, I wonder if it's this MCAS thing Sonal taught me about. Well, how do I work them up? Is there a specific test we can do? You kind of alluded to some of this, but how many of these tests are really readily available for the clinician?
Actually, the tests are pretty easy, and I will just go through the steps that one can follow. So if you're seeing a patient who has this episodic systemic mediator release type symptoms with multi-organ involvement, and they are, you're ruling out some of the original mimickers that we already just went over, your next thing to do would be a serum tryptase. Now, a serum tryptase, just one value by itself is not going to be enough. So you want to have a level already measured in a suspected patient when they're not having a flare. So that's their baseline. Then you can go ahead and get another. I have a standing order for the patient. So when they're having a flare, one of their symptoms, and they can go to the lab and get the blood drawn again for serum tryptase. Now, if there is an elevation, and there's this delta over baseline concept there, which is like 20% plus 2 approach. So if it is that, if you're getting a 20% plus 2 number, that is a true elevation, and that is a mast cell activation flare that is happening right now. It doesn't always have to go into this serious increase in order to call it that. So it has to be comparable to the patient's own baseline. And it can, sometimes people are not able to do that in that moment. So then they can still record their symptoms on what happened during that particular episode. And then, of course, in order to get a proper diagnosis, they have to do it during the flare. So I will just keep getting the serum tryptase orders for them. Practically speaking, I feel like as much as people are suffering, sometimes they're just not able to make it to the lab during their flare. And the answer again is that, hey, we have these orders in, go in and get it done. So if they're having an anaphylaxis-like episode, or if they're having one of their episodic findings, symptoms, this is what they need to do.
And what about getting these urine tests? Do you ever utilize the urine tests for some of these metabolites?
So urine tests are available, yes, but it is not diagnostic. It is not part of the criteria. So this is what's going to truly label them. And there's a lot of supportive things that one can find through other testings as well. Like I mentioned earlier, there are, and nothing diagnostic here. We're not talking early, without diagnosing Ehlers-Danlos syndrome or anything, because there's not always a great one genetic test for it. You're looking again at a mishmash of clinical criteria. But if there is that overlap, some of the other things can also give us insight into what the flare could be coming from and what we want to treat, like what is high in this person. But the urine tests are, they are like minor, and this is the most important thing we want to do.
Got it. And I think the point here is that, you mentioned early on that there are three real things you're looking for: good history of this recurrent episodes, and then the symptoms and different organ system that you can elicit with your question. And then, getting the test sometimes can be tricky. So even if you don't have that, but you have an index of suspicion, you can use some of these corollaries, like these associations, genetic associations you mentioned, and other things. But at the end of the day, you may need to rely on kind of good history to get you along the way in terms of designing a treatment plan, right?
Yeah. And I mean, if a patient can go to the lab and get their serum tryptase, I mean, that's much easier than doing their, like a 24-hour urine collection. That is a bigger ask. But the things that you were mentioning, like there's urine prostaglandin D2, and there's another 11 beta prostaglandin F2 alpha, and leukotrienes. Like all these histamine related mediators can be higher, but they are harder to get done. And this
Yeah.
is like the easy way to do it. So yeah.
Oh, so
Yeah, no, that's
I
this
kind of
is
want to ask the question that I think is the elephant in the room sometimes with
Huh?
activation, which is, it is a controversial diagnosis. So can you just raise some opinions on why is it considered controversial, and what is it that would make it not controversial for you?
I think labeling is helpful in diseases. So I am by nature a lumper because it helps me understand the concept of a problem. So I can at least enter the problem from somewhere when it is a very confusing situation. But sometimes being a lumper has its problems because then everybody starts like getting labeling with very broad diagnoses. That's what's kind of happened with mast cell activation syndrome. That's why these criteria are so important to follow, because if we are overdiagnosing them, then everybody is getting this title of this condition and they're seeking treatment options which may not be right for them. And most importantly, we could simply miss the other diagnoses which they truly have, such as CSU, and then using treatments towards that. Or like there's this other condition called hereditary alpha tryptosemia, which is actually a copy number mutation, autosomal dominant mutation in a gene TPSAB1. Now, if you miss that, that is actually not that uncommon in the general population, and patients can just present with the similar symptoms. So we knowing what are you treating, because there are specific treatments that will work much better. They will respond really well to certain common antihistamines, but they do have a higher risk of anaphylaxis, that this particular condition, the hereditary alpha tryptosemia. So knowing what it is, when we do know more about that condition, especially we know there's a genetic mutation associated, it is helpful to classify. That's why I think sorting through this is important. But again, like, practically speaking, a lot of people do come in and they raise suspicion for MCAS. I think as dermatologists, because we can at least see the skin, we can do the review of symptoms, we are already dealing with a lot of these mimickers, we can be pretty frontline in starting the process for a lot of patients.
That was excellent. You mentioned this idea of anaphylaxis that's a risk. Are there any other red flags, things we should be on the lookout for, and of course educate our patients about?
I think I think one of the things that I just mentioned, one of the common condition, well, not that common, but it is common between the population more than we would think. This hereditary alpha tryptosemia. Some of these other things that can come along, like if the patient is having hypotension, syncope or pre-syncope, is having, say, airway symptoms or severe systemic symptoms like anaphylaxis, like physiology. I think that is not something that we should start, like, continue to handle. I think we should refer patients at that point. I feel like allergy immunology colleagues will be great people to refer, but also, like, in order to get that correct diagnosis, the workup needs to start in time. But the biggest red flag is a lot of other symptoms. GI cramps, obviously that's not life or death, but I think it is significant enough it's happening in a recurrent way. So a gastroenterologist who is well versed in MCAS, and I think there are a lot of specialists now out there who are more knowledgeable about the criteria and following all these list of things that we just talked about. So patients should be referred to them. So red flags would be anything that would be life-threatening and dangerous, like I mentioned, and then sending the patients to the right specialist in the right time to diagnose or to rule out the diagnosis too will be very
No, this is
important.
great, Sonal. I really appreciate you taking us through a space that is developing, has largely, unfortunately, been overlooked, I think, and has kind of been criticized for being vague. So I think bringing some more specificity to this is really important. So to dive back, and I know you kind of probably talked about this, but just to dive back into the dermatologist space, because MCAS can show up in so many different
Yes.
clinics and so many different specialties. And and when I go to conferences, usually it's not the dermatologist giving the lecture on MCAS, ironically. So, what are you'd say like maybe the top 3 or 4 diagnostic things you're looking for on the skin that would clue you in that hey, I need to now go and ask about history or go and ask about other things that we normally wouldn't do, but perhaps you get triggered to do that.
Yeah, I think there's more in the history. So the patient is coming in with a certain symptom and they are telling, so I
But what
think
I meant is, are
asking
there
them,
dermatological
um,
signs before you get to like the
yes.
history or like digging deeper? What are some of the signs that like a dermatologist might be able to list?
So yeah, not not on the list of criteria, but I'll say this. When I see patients, just because there is a huge overlap with hypermobility, and if I see a patient who, it's very easy to do a Baton score on a patient. So according to the 2017 International Classification of EDS, there's like 13 types of EDS. One of them is the
Can you
hypermobility
explain what
type of
EDS
EDS,
is and
Ehlers-Danlos syndrome.
how that overlaps with MCAS?
Yes. So EDS is your Ehlers-Danlos syndrome, and that's a proper syndrome that is still actually diagnosed more in a clinical way because we do not have one known single genetic test for it. So it still has that multi-part criteria where you're looking at generalized joint hypermobility, and then additional certain systemic features, family history, musculoskeletal complications, and also, again, exclusion of certain alternative diagnoses, which are other heritable connective tissue disorders. And it's a mouthful, but truly, like, it is part of it is diagnosis of exclusion, but at the same time, patients having a generalized joint hypermobility, this is something that is actually undergoing some change, this diagnosis and this criteria, believe it or not, as we speak. So I I think because I have hypermobility, I have a lower threshold to look at patients at their translucency of their skin, or looking at the color of the veins over their hands, the extensibility of their skin, and a lot of the times that, and also their body habitus and posture, there's a slightly lower tone in their body, in the way they sit. They will often like cross their legs. Like, this is not written in a textbook, but in maybe in some textbook it's going to be mentioned soon. But working as an like a HEDS sort of expert, I can call myself, because I've seen so many patients by now, and with some of the other experts in my own university, we often recognize these common things, and so the radar for that is, hey, you have something going on. I'll also give you an example. I have had young patients who come in with multiple, like, they'll be in a boot and they will have like a tape on their arm, and probably are athletes, but interestingly, I always bring this up just from this personal interest point of view. I'm like, so what's going on with your arm and your leg at the same time? They'll be like, yeah, I sprain them very easily. And as they're telling me, they have no idea why that's happening to them. And I would, because of this low threshold for me to ask these questions, I often ask, like, do you get hives, or do you get, it's like, oh my God, I always have stomach upset since I was a child. Like, I have very sensitive stomach. I have IBS. And then they will throw some of these, conditions which are considered psychosomatic, nervous system, like where the nervous system is heavily involved. And this is how a sort of a can of worms open, which a lot of providers are scared to open. It excites me because I know where I can take this. So just looking at the skin, it can give you so many indicators. You just have to train that a little bit by seeing a lot of patients. Almost like a lividoid appearance on lighter skin is very easy to see, the translucent skin that I was alluding to earlier. So these are things you can quickly see at the skin. And if you have that suspicion, Baden score, which is a score out of 9, and you test a few of the joints, including like, you can check a thumb and you can check hyperextension of the elbows, takes like 30 seconds. And that can give you an idea, rough idea. This is not the one and only thing, but this is what we have so far to say, hey, you are pretty hypermobile. And some of that can start linking to why their mast cells could be destabilizing so easily. And maybe this is the first time we're talking about this in this manner, because I have still not, even though we've had informal discussions about this, and this is getting researched as we speak, any kind of stressor can throw mast cells off. We already know that. So is the mast cell instability truly happening because the joints, the proprioception in EDS is so poor? So constantly, all our joints in our body are trying to find their place. The connective tissue everywhere in the body is abnormal, right? So when this is happening, even on a spectrum, say somebody has a little more, somebody has a little less, what is happening to these mast cells? They are under threat and stress constantly. So they are degranulating even in the absence of a true, or rather a more identifiable stressor. So that is why there's a lot of overlap between people who have HEDS or a hypermobility spectrum disorder and having this mast cell instability. Now, how many of them actually have MCAS is again a big question mark because of the over non-proper diagnosis.
That was excellent, Sunil. Thank you so much. For our patients or clinicians, are there any online resources they can utilize? Are there any patient organizations, any foundations that are trying to bring together resources and build a community?
Yes, so there's the EDS Society that covers a lot of MCAS. There's also a whole body literally called the MCAS Society. And I would highly recommend anybody who wants to learn more about this, a distant colleague who is an anesthesiologist by trade, Dr. Linda Bluestein, her podcast called The Bendy Bodies, and she really teases out the difference between mast cell activation syndrome, where it's accurate, how to go about it, brings in some really, really high-level experts on the topic. I learn a lot from them as well, and covers a lot of different aspects of MCAS, but also like the related conditions.
Wow, incredible. Well, folks, there you have it. We started so vague, and now not only do I have clarity, I'm actually excited. I want to go to clinic and take a look and find these patients.
Are you itching for getting this underway in the clinic, Hadar?
Oh, yeah, I'm totally excited. This is happening. I'm going tomorrow to clinic and I'm going to find these patients. But no, we don't want to overdiagnose. But really, I really appreciate, Sonal, your expertise on this, because we took something that's very vague. And as you mentioned, a lot of this stuff is like, oh, I have upset stomach. I'm not sure why I'm getting, connecting to the hypermobility. I'm getting injured all the time. It's all these like vague things that, a lot of times we judge or prejudge early. Some parents come in and say, oh, I don't know, he's just, making it up, or all these things that we have. But here we can be a great doctor for our patients and leverage some of the signs in the skin and asking the right question and kind of developing that sixth sense that we are so good at as clinicians. So now you took us through this training. I feel pumped. I feel ready to go. Thank you so much for your time, for your expertise, and I'm looking forward to seeing you at IDS and seeing you in another episode of the Learn Skin podcast. Thank you.
Thank you so much for having me.
And that's a wrap for today's episode. But if conversations like this get you all excited, that's exactly what the Integrative Dermatology Symposium is all about.
And I'm all excited about it. The 9th Annual Integrative Dermatology Symposium will once again bring together clinicians, researchers, and educators who are shaping the future of dermatology. And this year, there'll be a focus on precision, regeneration, and whole person skin health. It's happening from August the 20th to the 22nd at the Grand Hyatt Indian Wells in Palm Springs, California.
IDS is where evidence meets application. Through expert-led sessions, real-world case discussions, and meaningful collaboration, or in plain English, IDS is where you get to talk to a whole bunch of people who are equally skin-obsessed.
I'm also equally skin-obsessed. If you want to be a part of the largest community in integrative dermatology, use the code PODCAST15
for 15% off registration at integrativedermatologysymposium.com.
That's integrativedermatologysymposium.com. We can't wait to see you there.